If you have been prescribed amlodipine or if someone you love is taking it right now, there is something important happening inside your body that your prescribing appointment almost certainly did not cover. Amlodipine is one of the most widely prescribed medications in the world. Tens of millions of people take it every day. And most of them take it in exactly the same way. They open the bottle, swallow the tablet, and trust that the medication is doing what it is supposed to do. But taking amlodipine without understanding it means you are missing half the picture. Because what this medication is doing at the cellular level, why certain side effects happen, what your body is trying to tell you when they do, what makes the medication work better or worse, and how your daily habits interact with every milligram you take are all things that change how safe and effective this medication is for you specifically. And most people have never been told any of it. Stay with me until the very end, because there is one interaction I am going to cover toward the end of this video that millions of people taking amlodipine are completely unaware of, and it involves something most people consider entirely harmless. Before I continue, everything I share today is for educational purposes only. It is not medical advice. Do not stop, adjust, or change your amlodipine dose without first speaking to your healthcare provider. This video is about understanding your medication more deeply, not replacing the guidance of your provider. I am Dr. Adebayo, and I have spent over 15 years specialized in senior health, working exclusively with adults over 60. I have seen what happens when patients understand their medication versus when they simply take it. The patients who understand it ask better questions. They notice important changes earlier. They make the lifestyle choices that help the medication do its job, and in many cases, over time, they need less of it. If you are new here, welcome. Subscribe right now and ring the bell. Every week, I bring you the information your provider cannot deliver in a standard appointment. This is where you get the deeper picture. Let me start with what amlodipine actually is and why it was created. Amlodipine belongs to a class of medications called calcium channel blockers. It is a long-acting dihydropyridine calcium channel blocker, which means it works primarily on the smooth muscle cells of blood vessel walls, and it stays in the system long enough to maintain its effect across a full 24-hour period from a single daily dose. It was first approved in the early 1990s and has since become one of the most prescribed antihypertensive medications globally because of a specific combination of features. It is effective, it is well tolerated by most people, it does not require twice daily dosing, and decades of research have confirmed its ability to reduce major cardiovascular events. But to understand how it does this, you need to understand what calcium is doing inside artery walls in the first place. Inside every smooth muscle cell that lines your blood vessel walls, calcium ions play a critical regulatory role. When calcium enters a smooth muscle cell through specialized channels in the cell membrane, it triggers a contraction. The cell tightens, the artery narrows, blood pressure rises. This is a normal, constant process that your body uses to regulate blood flow, adjust to physical demands, and respond to stress. When this process becomes chronically overactive, as happens in hypertension, too much calcium enters these cells too consistently. The arteries remain in a state of partial or full constriction far more often than they should. The heart must work against this elevated resistance continuously. Blood pressure stays high, and the cumulative damage to the arteries, the heart, the kidneys, and the brain accumulates. Amlodipine blocks the calcium channels in arterial smooth muscle cells. When the channels are blocked, less calcium enters the cells. The cells cannot contract as forcefully or as frequently. The arteries relax. The diameter of the vessel increases. The resistance to blood flow drops. And as resistance drops, blood pressure falls. This is called vasodilation, and it is the core mechanism through which amlodipine achieves its blood pressure lowering effect. Research published in the Journal of the American College of Cardiology found that amlodipine reduced systolic blood pressure by an average of 8 to 10 millimeters of mercury in adults with stage 1 to stage 2 hypertension. The ALL-HAT trial, one of the largest cardiovascular outcome studies ever conducted, followed over 42,000 adults and found that amlodipine was as effective as other first-line antihypertensives in preventing stroke and heart attack, with particular effectiveness in reducing stroke risk. Type the word amlodipine in the comments right now, because what you are about to hear next is information that most people on this medication have never received and genuinely need. I want to tell you about Gerald. Gerald was 74, a retired civil engineer from Dublin, Ireland. He had been taking amlodipine for 4 years. He came to me with two specific concerns. First, his ankles had been swollen since approximately 6 weeks after he started the medication. His previous provider had acknowledged the swelling and told him it was a known side effect. No further explanation was offered. Second, Gerald had noticed that despite taking his medication every day without fail, his blood pressure readings at home were inconsistent. Some mornings he would read 128/79. Other mornings, without any obvious change to his routine, he would read 151/91. He could not explain the variability, and neither, he felt, had anyone else. When I reviewed his complete picture, two things stood out immediately. Gerald ate grapefruit regularly, typically a half grapefruit with breakfast most mornings. And he took his amlodipine tablet inconsistently, sometimes in the morning with breakfast and sometimes in the evening when he remembered it. Both of those habits were directly affecting the behavior of his medication. We made two changes. The grapefruit was eliminated entirely. The amlodipine was moved to a fixed, consistent evening time every day. 6 weeks later, his home readings had stabilized to a consistent 129 to 133 range. The swelling, which I also explained properly for the first time, was real and addressable with a specific positional strategy. He described the appointment as the first time in 4 years of taking this medication that he felt he actually understood what was happening. Now, let me explain the side effects, because they are not arbitrary. They are biologically meaningful. They tell you something specific about how the medication is working in your body. The most common side effect of amlodipine is peripheral edema, which means swelling, most commonly in the ankles and lower legs. This affects approximately 10 to 15% of people taking amlodipine, and the incidence increases at higher doses. Here is why it happens, and it is not what most people assume. When amlodipine dilates arteries, it does so more powerfully on the arteries that carry blood toward the tissues than on the veins that carry blood back. The result is a hydraulic imbalance. More blood is delivered to the capillary bed in the lower legs than the venous system can efficiently return upward against gravity. Fluid shifts from the capillaries into the surrounding tissue. The ankles swell. This type of swelling is called dependent edema. It typically worsens through the day as gravity accumulates the effect, and it often reduces overnight when the legs are elevated horizontally during sleep. This is different from the swelling caused by heart failure or kidney disease, which is typically present on waking and is accompanied by other symptoms. Managing amlodipine-related edema does not usually require stopping the medication. Elevating the legs for 30 minutes twice daily, compression stockings during waking hours, and avoiding prolonged standing reduce the fluid accumulation significantly. However, if the swelling is sudden, severe, involves one leg significantly more than the other, or is accompanied by warmth and redness, those are different symptoms requiring immediate medical evaluation. The second most commonly reported side effect is flushing, a sensation of warmth or redness, particularly in the face and upper body. This is a direct consequence of vasodilation, specifically the dilation of superficial blood vessels near the skin surface. It is typically transient, more common when first starting the medication, and tends to reduce over the first 2 to 4 weeks as the body adjusts. Headache in the early weeks of amlodipine therapy is also a vasodilation effect. The blood vessels supplying the brain undergo the same relaxation as peripheral vessels. As cerebral vascular tone adjusts to the new vasodilatory environment, headaches can occur. They typically resolve within the first month, Fatigue and dizziness, particularly on standing, are worth monitoring closely. When blood pressure is actively being lowered, postural hypotension, a temporary drop in blood pressure when moving from seated to standing, can occur. This is more significant in adults over 60 because the compensatory mechanism that normally adjusts pressure rapidly on standing becomes slower with age. If you experience dizziness when rising from a chair or bed, rise slowly. Pause at the seated position before fully standing and report the symptom to your provider as dose adjustment may be appropriate. I want you to type your age in the comments right now and add the word Amlodipine, because someone in that comment section, possibly someone who has been experiencing ankle swelling for months and received no explanation, is going to read this and feel less alone and more informed. Think about one person in your life who is on blood pressure medication and has been told about a side effect without being told why it is happening. Share this video with them today. Understanding the biology behind a side effect changes a person's relationship with their treatment. That matters. And if you are not yet subscribed, do it right now, because the section I am about to cover on what affects how amlodipine works in your body is the most practically important information in this entire video, and you do not want to miss it. Let me now cover the critical factors that affect how amlodipine performs in your body. Factor 1, consistency of timing. Amlodipine has a long half-life of approximately 35 to 50 hours. This means that the medication takes several days to reach a stable plasma concentration after you start taking it, and it takes approximately the same number of days to clear from your system if you stop. This long half-life is actually a pharmacological advantage because it means a single missed dose does not immediately destabilize your blood pressure control the way a short-acting medication would. However, this does not mean timing is unimportant. Research published in Hypertension found that morning blood pressure surge, the spike in pressure that occurs in the early hours of the morning as cortisol rises and the body prepares for activity, is associated with an increased risk of cardiovascular events. Evening dosing of amlodipine has been studied as a strategy to specifically provide coverage during this vulnerable period. A study in the Journal of Clinical Hypertension found that adults who took amlodipine in the evening had significantly better nocturnal and early morning blood pressure control compared to those taking it in the morning. The absolute difference in blood pressure reduction between morning and evening dosing was not dramatic, but the coverage of the highest risk window of the day was meaningfully improved. The practical guidance is this: choose a consistent time and take it at that time every day. Whether morning or evening is secondary to consistency. Your pharmacist or provider can advise on the optimal window for your specific profile. What creates variability in blood pressure control is inconsistent dosing timing, not the choice of window itself. Factor 2, grapefruit and grapefruit juice. This is the interaction I mentioned at the opening, and it is one of the most important and most consistently underestimated drug interactions in common medication use. Grapefruit contains compounds called furanocoumarins. These compounds irreversibly inhibit an enzyme in the small intestine called CYP3A4. CYP3A4 is one of the primary enzymes responsible for metabolizing amlodipine before it enters the bloodstream. When this enzyme is blocked by furanocoumarins, amlodipine is not metabolized normally in the gut. More of the drug passes into the bloodstream than intended. The plasma concentration of amlodipine rises above the prescribed dose. A standard 5 milligram tablet of amlodipine taken with grapefruit juice can produce blood plasma concentrations equivalent to a significantly higher effective dose. This means blood pressure may drop further than intended. The risk of excessive vasodilation increases. Side effects, particularly dizziness, flushing, and ankle swelling, intensify. And the risk of hypotension, dangerously low blood pressure, rises. The furanocoumarins in grapefruit bind to CYP3A4 irreversibly. This means the effect lasts not just for the hours after eating or drinking grapefruit, but for the entire lifespan of that enzyme, typically 24 to 72 hours. Eating half a grapefruit on Monday morning and taking your amlodipine on Tuesday is not safe spacing. The enzyme remains blocked. the interaction persists. Whole grapefruit and all grapefruit juice, including fresh squeezed, must be avoided entirely while taking amlodipine. Oranges, lemons, and limes do not contain foreign coumarins in significant amounts and are safe. Seville oranges, which are used in some marmalades, do contain foreign coumarins and should also be avoided. Factor 3, alcohol. Alcohol enhances the vasodilatory effect of amlodipine. Both substances lower blood pressure. Combined, their effects are additive and unpredictable. The most significant risk is sudden hypotension, a rapid drop in blood pressure, particularly when standing. In adults over 60 who already have a slower postural blood pressure compensation mechanism, this can cause falls, dizziness, and in severe cases, loss of consciousness. Moderate alcohol consumption, defined as no more than 1 drink per day for women and 2 for men, is generally considered manageable alongside amlodipine for most adults in good health. However, any consumption beyond moderate levels significantly increases the risk of blood pressure instability and adverse events, and the interaction is dose dependent. More alcohol, more risk. Factor 4, sodium, potassium, and dietary patterns. Amlodipine lowers blood pressure through vasodilation. A high sodium diet raises blood pressure by increasing blood volume. These two forces work directly against each other. An adult eating 4,000 milligrams of sodium per day while taking amlodipine is simultaneously fighting their own treatment. Research published in the American Journal of Hypertension found that adults on antihypertensive medications, including calcium channel blockers, who adopted the DASH diet, achieved blood pressure reductions that were additive to their medication effect. In practical terms, this means the DASH diet was working in the same direction as the medication and amplifying the total reduction. Potassium specifically has been shown to enhance the blood pressure lowering effect of antihypertensives. A meta-analysis in the Journal of the American Heart Association found that adequate potassium intake achieved through dietary sources such as leafy greens, legumes, and root vegetables was associated with a 3 to 4 mmHg additional systolic reduction in adults already on antihypertensive medication. Factor 5. Physical activity and its cardiovascular synergy with amlodipine. Exercise lowers blood pressure through nitric oxide production and improved arterial elasticity, as I covered in our blood pressure video. What is important to understand here is that this mechanism is distinct from and additive to the calcium channel blocking mechanism of amlodipine. They lower blood pressure through different pathways simultaneously. Research published in the Journal of Hypertension found that adults with hypertension who combine antihypertensive medication with structured aerobic exercise achieved greater blood pressure reduction than those on medication alone, with the combined effect reaching reductions equivalent to a dose increase of antihypertensive medication. The exercise was, pharmacologically speaking, augmenting the medication's effect. For some adults, consistent structured physical activity has been associated with being able to reduce antihypertensive medication dose over time under provider supervision. This is not a guarantee, and it is not appropriate for everyone, but it reflects the biological reality that exercise and medication are not competing. They are complementary interventions working through different mechanisms toward the same arterial outcome. Factor 6. Other medications and interactions. Amlodipine is metabolized by the CYP3A4 enzyme system. This means that any other medication or supplement that inhibits or induces this enzyme will affect amlodipine's plasma concentration. Inhibitors of CYP3A4 increase amlodipine levels. These include clarithromycin and erythromycin, certain antifungal medications including itraconazole and fluconazole, and certain HIV medications. If you are prescribed any of these while taking amlodipine, your provider should be aware of the potential for increased amlodipine effect. Inducers of CYP3A4 decrease amlodipine levels, potentially reducing its effectiveness. These include rifampicin, an antibiotic used in tuberculosis treatment, and certain herbal products, including St. John's wort, which is commonly taken for mood support without recognition of its pharmacological interactions. St. John's wort is available without prescription in most countries. Many adults take it alongside prescription medication without realizing it can meaningfully reduce the effectiveness of their antihypertensive treatment. If you take any herbal supplement, please inform your prescribing provider. Not because herbs are dangerous in general, but because their interactions with prescription medications are real, documented, and worth managing explicitly. Now, I want to address what happens when amlodipine is doing its job correctly and what additional steps you can take to reduce your long-term cardiovascular risk beyond what the medication alone can achieve. Amlodipine manages blood pressure. It reduces the ongoing damage to arteries caused by elevated pressure. It lowers the risk of cardiovascular events. These are significant and real benefits, but it does not reverse arterial stiffness that has already developed. It does not correct the underlying dietary patterns, sleep deficits, or stress physiology that are contributing to elevated pressure. It does not address visceral fat, sedentary behavior, or the sodium-potassium imbalance that is working against your treatment. It manages the pressure output while the underlying inputs continue operating. This is why the research is consistent that lifestyle modification alongside medication produces better outcomes than medication alone. The medication is doing the job you cannot feel happening. The lifestyle changes are addressing the sources that the medication alone cannot correct. Evelyn was 71, a retired librarian from Edinburgh, Scotland. She had been on amlodipine 10 milligrams, the maximum standard dose, for 6 years. Her systolic had never dropped below 145 on that dose. Her cardiologist had begun discussing adding a second antihypertensive. When I assessed her lifestyle, the pattern was consistent with what I see repeatedly. She was sedentary, sleeping fewer than 6 hours per night, eating a diet high in processed food and low in potassium-rich vegetables, under chronic low-grade stress from caring for her elderly mother, and had been unknowingly consuming St. John's wort for depression management, prescribed by a separate provider who had not cross-referenced her cardiovascular medication. We stopped the St. John's wort in coordination with both her providers, substituted a medically supported alternative, corrected her dietary pattern toward the DASH framework, implemented a daily 20-minute walk, addressed her sleep window, and established a daily breathing practice. 12 weeks later, her systolic had dropped to 134 without any change in amlodipine dosing. The discussion about adding a second medication was suspended. Her cardiologist was not surprised. She had not known any of this was possible. She had assumed the medication was the ceiling of what was available to her. It was not, and for most people on amlodipine, it is not. The medication is a floor, not a ceiling. What you build on top of it determines how far your outcomes can improve. Here's the practical summary. What you can do right now to help amlodipine work at its maximum effectiveness and reduce your overall cardiovascular risk. 1. Take your amlodipine at the same time every day. Choose a time you will not miss. Many adults find evening dosing before bed the most consistent anchor. If you currently take it inconsistently or have missed multiple doses recently, speak to your provider about the best way to restabilize. 2. Eliminate grapefruit and grapefruit juice entirely. Replace with oranges, apples, berries, or any other fruit without furan or coumarin content. This is not optional. The interaction is real, consistent, and directly affects the concentration of medication in your blood. 3. Move toward the DASH dietary pattern. Reduce sodium below 2,000 milligrams per day. Increase potassium through leafy greens, legumes, sweet potato, avocado, and whole fruit. This is working in the same direction as your medication, not separately from it. 4. Add 150 minutes of moderate aerobic activity per week. 5 30-minute walks. This is proven to augment antihypertensive medication effect through a completely independent mechanism. It is the most evidence-based, non-pharmacological blood pressure intervention available. 5. Prioritize 7 to 8 hours of sleep per night. Consistent sleep timing supports nocturnal blood pressure dipping, the overnight recovery window that medication alone cannot provide. 6. Disclose all supplements to your provider, particularly St. John's wort, high-dose vitamin E, and any herbal products marketed for cardiovascular or mood support. Some of these have documented interactions with CYP3A4 that directly affect how your amlodipine behaves. 7. Monitor your blood pressure at home and keep a log. Bring the log to every appointment. Patterns in your home readings, particularly the morning surge and any readings taken 2 hours after your medication dose, provide your provider with far more clinically useful information than a single office reading. Before we close, 3 important warnings I want to leave you with. Warning 1. Do not stop amlodipine abruptly without provider guidance. Unlike some antihypertensives such as beta blockers, amlodipine does not typically cause rebound hypertension on sudden cessation. However, stopping it removes the vasodilatory protection your cardiovascular system has been depending on. Your blood pressure will return toward its pre-medication level. If you want to reduce or stop amlodipine, work with your provider to do it safely and only when lifestyle changes have demonstrably and consistently reduced your pressure. Warning 2. Report severe or sudden ankle swelling, difficulty breathing, chest tightness, or a dramatic change in your blood pressure readings to your provider immediately. While mild ankle swelling from amlodipine is benign and manageable, sudden severe edema can indicate the medication is producing too much vasodilation for your cardiovascular system to compensate for, or it can indicate a separate issue requiring investigation. Warning 3. If you are taking amlodipine and your blood pressure is still not controlled, do not assume the medication is simply insufficient. Before dose escalation or adding a second agent, ensure grapefruit is absent, ensure no CYP3A4 interaction medications are present, ensure sodium intake is not neutralizing the effect, and ensure sleep and stress factors are not driving uncontrolled readings. I have seen many cases where addressing one of these factors restored control without any change to medication. Here is your complete recap. Amlodipine works by blocking calcium channels in arterial smooth muscle cells, preventing contraction, reducing arterial resistance, and lowering blood pressure. Its most common side effect, ankle swelling, is caused by a hydraulic imbalance between arterial dilation and venous return and is manageable without stopping the medication. Evening dosing provides better coverage of the high-risk morning blood pressure surge. Grapefruit irreversibly blocks the enzyme that metabolizes amlodipine and must be eliminated entirely. Alcohol amplifies its vasodilatory effect unpredictably. Sodium works directly against its mechanism. Exercise, the DASH diet, sleep, and stress reduction all amplify its effectiveness through independent biological pathways. And St. John's wort reduces its plasma concentration, potentially making it significantly less effective. You are not simply a patient taking a pill. You are an active participant in a cardiovascular system that responds to everything you do. Your medication is a floor. Your habits are what determine how high above that floor your health can go. If this video gave you something your prescribing appointment did not, please subscribe before you go. Every week, I bring you the layer of information that goes beneath the prescription. You deserve to have it. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.